So this morning, Dr. Jason Smith is going to be speaking about blast injuries. So let's give him a great round of applause. Dr. Jason Smith.
So let me ask you a question. How many of you have personally had a concussion before or a brain injury? Okay, so keep your hands up if you were diagnosed by a medical professional for that concussion. Okay, so that's pretty much what usually happens is most of the people who have brain injuries don't end up showing up at the doctor and they just deal with it on their own. What we're going to talk about today is several different factors. We're going to talk about the most profound and dangerous type of concussion that exists, to my knowledge. We're going to talk about the mechanics of it, how the mechanisms of injury occur, some diagnostic and outcome assessments, and some interdisciplinary treatment recommendations. So why do I do what I do? You see my three sons there with my son's daughter-in-law, my son's wife, my daughter-in-law. Every one of those three boys have had a life-changing concussion at some point. And if you think about why you're here right now, you've probably all left some loved ones to be here and learn what we're going to be discussing today. There you can see one of the most amazing things that happened to me in the past year. My little granddaughter Quincy was born in May, and there's the other picture with Heather. But the reason why I do what I do is so I can help families. Of all the possible types of central nervous system injuries, there's numerous, traumatic and acquired. We're going to specifically talk about this one right here. Blast injuries. So that little 9-second video is Hollywood's rendition of what a blast means and how it looks and how it feels. Concussion and traumatic brain injury affects millions in America every year. The statistics vary. I've seen it as low as 1 million a year. I've seen it as high as 10 million a year, but needless to say, there's lots of families that end up suffering because of it. Most of the people who have brain injuries end up surviving. 52,000 a year die from their injuries, and only a small percentage of them actually seek medical attention. Of mild traumatic brain injuries, of course, we all know there's mild, moderate, and severe brain injuries. Of the ones that survive, 90% of the traumatic brain injuries are mild. And that doesn't mean the symptoms are mild, that just means it's not life-threatening. 15% of those people that survive end up having prolonged disability and long-term disability. So in terms of what are the symptoms of last TBI, a whole bunch of different symptoms. Everything from cognitive to speech to memory to sleep and all sorts of physical symptoms. And these are basically signs of disrupted networks. I like to memorize the 4 categories of concussion symptoms this way. Just this quick little acronym, SPEC, SPEC. And the S stands for sleep, P stands for physical, E stands for emotional, and C stands for cognitive. There's a whole bunch of symptoms that come under each of these categories. Cognitive include everything from brain fog to difficulty concentrating and remembering things, making decisions. Emotional, everything from anxiety to depression to anger outbursts. Physical, headache, dizziness, balance problems, all sorts of sounds and light sensitivities. And then asleep, there's sleeping too much and sleeping too little. As you can see in this diffuse tension image of a brain, there's a healthy brain on top. You see the networks all those axons are nice and connected. If you look at the bottom picture, you'll see that there's just a lot of disconnection going on. So what do you need to consider in treatment for traumatic brain injury that especially involves in blast injuries? And we'll talk about the physics of it in just a minute. Number one, you have to appreciate the magnitude of the injury. When we talk about the physics in just a moment, you'll see that the magnitude of these forces that are dealt with these explosives that can occur are so far greater than the simple sports concussion where someone falls and hits their head. And I'm not minimizing the amount of symptoms that those people can have, but the force is just so much different. There's also a widely expanded zone of injury. There's things that every fluid-filled or air-filled organ in your body, which were mostly made of water, gets affected. And then you have to, when you're treating these conditions, you have to anticipate injury progression. That means whenever you come into the scene, you'll have sometimes not fully realized realization of symptoms. Things will tend to progress over weeks and months and years. And sometimes by progress, I mean digress. So you have to be aware of infections, acute and delayed, and you also have to be aware for other organ injuries. So I borrowed this slide from Art Croft because I wanted to just illustrate to you some of the physics. If you look at the upper equation, you'll see a small a, and of course acceleration is very small because the change in velocity over the change in time is, there's a big time factor on the bottom. That's a crash that's something like a front-end collision where there's a lot of crush in the front hood. If you look at the bottom equation, the A is large, and these are more of the rear impact type collisions. That's what LOSRIC stands for, low speed rear impact collision. The acceleration becomes much higher because you've got usually a car that's still, and in a sudden instant, that velocity changes from stopped to suddenly moving. And the bullet impact vehicle ends up having a more ride-down time because of crush into the vehicle, but the person that just gets rear-ended, all that force gets transferred to their neck. So that's accelerations. Now, just a quick example. Look at the forces. Force equals mass times acceleration. That's Newtonian physics. Acceleration is basically a change in velocity with respect to time. So remember, it's meters per second squared, or foot per second squared. Now, we express that in force as a g, like we're under the acceleration of gravity right now at 1g, 9.8 meters per second squared, or 32 feet per second squared. So if we're going to take a car and accelerate it from 0 to 155 miles an hour in 6 seconds, we'd have an acceleration of about 37 feet per second. Now, I apologize, I am not a physicist. I couldn't figure out how to make that little squared number go up in my slide. But you get 37 feet per second is 37 feet per second squared. So that's pretty quick. You can generate some pretty substantial forces falling from a 2-story building or getting rear-ended in the range of 2 to 10, maybe sometimes 12 or 15 Gs, and you can definitely have injury. But blasts occur in such a short time at such rapid speed that you're looking at forces that are velocities that are in the order of 32,000 feet per second squared. It's extremely high. We're looking at 86 to 100 Gs that these people who are in blast injuries are experiencing. So if you take a bomb, put it in a room, and put some sensors on the walls and explode it and measure the forces that are involved, you're looking at a whole duration of the whole experience is the sensors receive input in about 5 milliseconds, 5 thousandths of a second, and it's over by 65 milliseconds. The research on the quickest reaction time in humans is about the fastest measured physical reaction time is 120 milliseconds, and on average, 250 milliseconds, to 300 milliseconds is sort of more average. So these forces are going through the brain at an extremely rapid pace. And I wanted to make sure I put this in now, so we have so many slides to cover, I want you to buckle your seatbelts. I just want you to realize from all my research, I've probably studied over 100 different blast papers, and I'll include about 10 of the ones that I think are the best with some of the forms that are going to be coming up. Blast-related injury is not just a simple concussion. Even if you don't have visual symptoms on an MRI, you are having all sorts of neurophysiologic dysfunction. It's different from blunt trauma. I want you to understand that blast-related injuries are on the rise. They're increasing, and it's just a matter of time that you need to prepare as a functional neurology practitioner to make sure that you're ready to treat some blast-related head trauma. So what are the sources of blast injury? Well, there's intentional and non-intentional. Industry accidents and fireworks and things like military combat and acts of terrorism are the non-accidental. Back in 2004, there was if you recall, there was an incident where 10 different improvised explosive devices exploded near simultaneously on a commuter train. And it was during rush hour. 191 were killed, only 1,800 wounded. Coming forward another year in London, there were 4 bombs. 3 were on an underground train. 1 was on this double-decker bus. 52 civilians were killed, 4 terrorists, and 700 were injured. In Boston, 2013, there were 2 explosive devices detonated to the finish line of the Boston Marathon. 3 were killed, over 200 were injured. And so basically, what we're seeing is that terrorism is on the rise in our country and in the world. And bombings are basically the most common methods of attack. And a story a little bit closer to home, if you think for you guys in the room, what were you doing on a day or 2 before Valentine's Day last year, the year before, any of those years? You're probably thinking, what do I got to get done? Well, there was a guy named Stacy. He was actually planning in advance 2 days before Valentine's Day on the 12th. February 12th, 2007, and he went into a shopping mall in Salt Lake City to purchase a Valentine's Day card for his wife. And there was a young 18-year-old that walked into the mall, holding a shotgun and a handgun, and just started shooting people. Stacy got hit at point-blank range 5 times, and surprisingly didn't die. Others weren't so lucky. There were 6 that were killed in that Trolley Square incident, and it wasn't until 3 months later when Stacy was able to finally come home from that shopping trip to go get a Valentine's Day card for his wife. 5 years later, I was able to hear his story as he became a paraplegic. 4 others were critically injured, and I was able to start really was what was my first blast treatment. And the kind of symptoms that Stacy experienced were pretty challenging. I don't know if you've ever treated, it's a combination of central and peripheral neuropathy, but Stacy still had some movement in his legs, and actually, as I started treating him over the next 6 months, he was able to start having some ability to take steps. He was working therapy probably still 4 to 6 hours a day, in addition to the treatment we did in my office. But he would have probably 20 to 40 episodes a day where he would start to feel severe spasms and contracture of his abdominal muscles, his back muscles, his thighs, and it just became very severe. Another case very similar to his described his neuropathy pain after a cord injury like this. He said for the last 20 years, he would have nightmares every night of several of the following things. One, he was laying on a table and he was he was being sawed in half by a saw, a table saw. Another one of his nightmares was he was dreaming that there was just someone dripping acid all over his trunk and his legs. Another one of his nightmares that he was being crushed by a tree. And Stacy had some of those type of neuropathy symptoms, and this other gentleman that I told you about, within probably 6 months, we were able to completely get rid of all those nightmares. And the thing that makes blast treatment so complex, in addition to all the normal neurophysiologic brain dysfunction, is we find that there's an added challenge, and that's the Ptsd, the post-traumatic stress disorder that goes along with it. There's just so many more factors to consider, and it's pretty insidious. So here you see a picture of one of our servicemen in the military, and military concussion has become epidemic with a comparison of the wars from the early Civil War to the World War I and II. There was something that became quite known called shell shock. I'm sure you've heard of it. And it was in the early 1920s when they first started realizing that there's more to these traumas these servicemen and women had experienced than just seeing something scary. Military concussion is now the signature wound of Operation Enduring Freedom and Operation Iraqi Freedom. Now, one thing you'll notice, if you look at the whiplash literature, you'll find that the amount of deaths that on our highways are actually decreasing over the last 10 to 20 years, but our actual injuries are increasing. And that's because of changes in safety and auto vehicle biomechanics and the way things are constructed. In military, there's also a similar pattern. We have increased brain injuries and neck injuries and head injuries, but less trunk injuries. And that's one of the big advances is body armor, and the training that they've done has really improved that. As far as combat-related blast injury, there is thousands of IED attacks in Afghanistan, and if you look at a recent statistic over the last, for this time frame, 230,000 TBI victims in the United States. So how are the injuries occurring in military combat? We have high-velocity weapons, landmines, and basically improvised explosive devices. So let's just talk about really quick how a blast occurs. And basically, a blast occurs when a liquid or solid is rapidly converted into gas. And that rapid conversion displaces anything in its path. And then you have a sudden rise in pressure, and then you'll have a slow decline in pressure over time. So see if you can see the blast wave here.
And there, finally, we can see the shock.
Finally, we can see the blast wave. So that is an example of the compression of air that actually bends and refracts the light. So that's why we can see it. So that's the quickest thing that happens is you see that blast wave, and pretty much the blast that's created is just hundreds of miles per hour. I think in a later slide I have it's about 7,000 meters per second. It's very rapid. And then suddenly, as soon as you have that rapid increase in pressure, you almost as suddenly have a rapid negative pressure that develops. And then the pressures return to normal as the gases diffuse. And you can see this classic Friedlander wave. On the left, you see just a simple blast overpressure in an instant, and then positive pressure phase is the area under this curve, and then you see a negative pressure phase, which if you think about brain tissue that undergoes that, you're suddenly, it's like a coup, contra coup in high speed. If you look at a different type of explosion, a pressure time curve in a closed space, you'll see that there's actually many more blasts that occur. And there's actually a much more space under this curve. So there's a lot more forces that occur. So let's talk about how blasts behave. When blasts occur, they act sort of like sound waves, and that means they can turn corners and they can go around objects. And the interesting thing about the reflections that occur in blast waves is you could have a thin piece of plastic or drywall or something, and that can reflect a blast force that's even higher than the initial force. So just in case any of you are ever involved in a blast that's about to occur in water, realize that blasts in water are more dangerous. Basically, why do you think that is? Why is a blast in water more dangerous? Density of water? Any other ideas? Water is essentially non-compressible. So when you're moving something at 7,000 meters per second through a non-compressible surface, that means it will definitely spread force into your body quicker. Now, if you like I said, if you ever happen to be in a water situation when you're going to experience a blast, well, let me ask you this question. Raise your hand if you think it'd be better to be vertical in the water, or would you think it'd be better to be on top of the water? Raise your hand if you think it's better to be vertical. It's hard to know, isn't it? No one says vertical? Okay, what about on top of the water? All right, we got a few takers. So you're right. The reason why you want to be on top of the water is because as the pressure increases with the water vertically on top of itself, the pressure of the water, that adds to the blast pressure as well. So if you're going to have an explosion, you need to be up near the surface of the water. All right. So there's a lot of calculations that have been made on how much force it takes to cause a skull fracture, how much it takes to make a brain injury, how much it takes to injure a neck. This is just some of the Wayne State calculations that shows that there is effective accelerations 600 Gs down to, approaching, 1 or 2 Gs that still can cause a skull fracture. So this is a good article if you want to read some of the basics. I'll just show you a couple scenarios on blast behavior. If you see the center of that area is the darkest where the blast occurred, and then there's some other people around. And in this, you just look at the trace of and they all have, I guess the military, a lot of them have sensors that they put on their helmets and their backs and different things so they can measure forces that occur, sort of like accelerometers in football helmets that they're using in the NFL now. But you see a pretty clean trace, just a slight amount of negative reflection. And then if you look at something like in a car, those MRAPs, those big 15-ton vehicles that transport soldiers around, there's an explosion that occurred in the cab of a truck, and you see the two individuals in the cab here, and this looks like a superior view, and this is the open window right here. And you can see that there's just a big initial reflection force with a large negative force with all sorts of reflections. And so, there's almost no doubt that these people received concussion, brain injuries, whether or not they had any immediate symptoms. But this rocket-propelled grenade hit the truck. So here's another one. This is someone in a watchtower, a couple people, and then the blast occurred over here. And so you'll see that because of this wall back here, I don't know if it's this one or this one, there's a secondary reflection that occurs. And they had a sensor mounted on the back of the head. Another one, even the people that are firing these rockets, you can see where the blast, the sensor, it's a really complex blast wave. But the peak overpressure, 36 psi, and then you see just a sort of Friedlander approach, and then you've got a ground reflection as well. Every single person, how you experience a blast is very unique. Just like whiplash injuries, you can have two people of very similar sizes, one in the driver's seat, one in the passenger seat, and they can have completely different experiences of force. Same thing with blasts. Here's another view of the peak overpressure. You just see the lot of pressure over here on this shoulder, and then it degrades as it goes forward. So this is something I didn't really know a lot about, but I thought I'd just, for sake of thoroughness, tell you a little bit about the types of explosives that are involved. And basically, I try to make it simple. There's high order and low order explosives. So what are low order? Low order is like gunpowder, potassium nitrite, and these burn with a velocity of about 1,000 meters per second or less, which means if you light gunpowder sitting in a pile on a table, it's just going to burn. It's not going to really explode. It only produces an explosion if it's confined, like a pipe bomb. And so, as you know, many terrorists choose to use those type of bombs to wreak havoc. Higher order explosives are different. They detonate much higher velocity at 7,000 meters per second and have a pretty significant overpressure even when they're unconfined. So they pretty much have liquid or solid, and then you have basically a primary explosion from the initial blast, and then you have a secondary. And you need to have an initiating explosion to detonate this. If you remember some of the old-time movies that, my wife likes to watch Little House on the Prairie, but there's others, John Wayne and others. If you want to take a story and make it a little bit more challenging, you just give someone the job to take a wagon full of nitroglycerin from one place across rough terrain to another place. And then, you have the effects of like dynamite being stored in an abandoned mine shaft, and how the nitroglycerin will sweat out from it, and how that can spontaneously combust. It's very real. Nitroglycerin is very unstable. Back in 1867, Alfred Nobel found a way to make dynamite, and he made it by making nitroglycerin more stable so that you could transport it and destroy things easier. You guys, anyone recognize this picture? So one of the most famous cases in neuroscience history, a clinical case, is a young 25-year-old in 1848 was in Vermont, and he was sort of tamping some dynamite or some kind of gunpowder into a hole. He was blasting a railway bed, and for some reason it exploded and took this about 4-foot long tamping rod that weighed about 13 pounds up through his left cheek, through the top of his skull, destroying his eye, up through his frontal lobe on the left side. And he wasn't knocked out. They took him to had some little disgusting pieces of brain that were about 100 feet away, but he ended up surviving, but it totally changed his personality. It's a very interesting read on one of the very first neurologic cases that helped us understand the different regions of the brain. As they say, a handsome but disfigured young man, Phineas Gage. So let's talk about classification of blast injuries. There's basically 5 types, 5 ways to classify this. Now, you have to realize that this isn't, it's a multi-dimensional way to separate these out, but they all happen in an instant. And so, we sort of do this so you can learn and think of the different types of injuries that occur, but they are sort of all happening at once. So the primary blast injury is the first. And basically, those are the thermal injuries that occur if you're really close to that blast zone. It's not as common because there's not as many people in that radius. But as you look, as that radius goes out, you have fragment injuries, which is the secondary penetrating trauma, and then the radius expands and you have other injuries. But as it says, these fragments can travel sometimes several miles. So, just to make it a little more memorable, there's primary is thermal, the second is the penetrating, and you think about it, that's the fragments that occur. The tertiary, can you think why you would have blunt trauma? Think back to the Hollywood movies. You're suddenly getting exploded. Think of Bruce Willis in an elevator shaft. It's coming up, fire's burning up the elevator shaft, and he turns a little bit and just gets thrown as this explosion comes up. That's the blunt trauma. That's, as you get thrown, you can hit your head on the wall or on the ground or something, and you can have an injury that way. The quaternary injuries are the other associated injuries, such as the chemicals and the asphyxiation from the dust and the chemical contamination. Now, we try to prevent. If you get exposed to the primary injury, the primary blast, that's when you have the highest likelihood of being killed, because your lungs are full of air with a lot of fluid in there as well, and it's something called blast lung. It's like acute respiratory distress syndrome. Your lungs actually lose the ability to transfer and absorb oxygen, and then you asphyxiate in a short time. But there's other causes, embolism. As a sudden blast of force goes through your blood vessels, it can actually cause an air embolism to occur. Maybe nitrogen comes out of solution, and then you just have an air embolism that can go into the lung or into the brain. And you can't forget blast gut, which is some kind of perforation that occurs in the gut. Usually causes necrosis, and those are more later onset. You have to look at those for about 48 to 72 hours, even if they don't have symptoms yet. So the most common type of injury is from the secondary blast. So you have that sudden blast wind that goes through, and it moves everything in its path. Everything from dust to rocks to fragments, and terrorists like to add a whole bunch of these little fragments to make their bombs more deadly and fatal and cause more trauma. They'll add ball bearings and nails and rocks and even sometimes feces to their bombs to make it more highly likelihood to cause infection. So you can affect thousands of meters away from the center of that. Just a little picture of some of the fragments from the bomb. So we talked about the tertiary blast injury. Basically, the big key take-home on this part is the injury may not come from the bomb directly, but if you're in a building or near a natural structure that collapses, a tree or something, you get structural collapse, and then you get a lot more of the crush injuries to your head as those occur. So you look at this roadside bomb, this picture here, and you see that this IED that was planted there basically lifted that heavily armored vehicle over 15 tons and flipped it on its side. So what kind of injuries can occur there? Well, you can get injured, you could survive the actual blast, but then, you can hit your head inside the vehicle, and there's also significant increased risk of fracture, and you can see, as that MRAP vehicle gets an explosion underneath, the spine is suddenly compressed from inferior to superior, and you get all sorts of chance fractures and thoracolumbar injuries and compression fractures, and you think you're protected inside that vehicle, but those forces transmit right through. So, this Oklahoma City bombing was if I remember right, it was a vehicle that was parked in front of the building, and it was a specific potassium nitrite bomb or something. And up until this time, it was the worst terrorist act on our American soil. 168 were killed, 19 were injured, 19 children were killed, and hundreds and hundreds and hundreds were injured. So what kind of order explosives do you think this terrorist attack had? Is this high order explosives or low order explosives? So we got a jet flying into a building. Low. Yeah, so it's a big, huge pile of, a big, huge projectile with a whole bunch of jet fuel in it. And that's what caused it. Once it hit that, it exploded. But it basically was a low order explosion that caused substantial trauma. Over 2,600 deaths, and many more injured, and many, many, many suffering right now. So at this point, a quaternary blast injury is things like burns and crush injuries and things that occur afterwards. For some reason, people who have been exposed to blasts end up with hypertension and a whole host of psychological consequences. Your review of systems is important. When you look at all the different organ systems that can be affected, you have to realize that as functional neurologists, we're not going to take care of these acute cases. Usually they're going to be triaged in the hospital, but you still have to be aware that there can be trauma at all of these areas. So I'm going to fly through this. This is another article in the Lancet of Neurology, which shows a picture of about 17 different ways that the brain can get injured, from every direction, through the sinuses, up through the nose, from the blood vessel up in the carotids, going up, shock waves up through the fluid, reflections off of the skull, penetrating fragments in the skull, several different ways. And if you look at this oddly shaped interior of the skull, you'll see that there's all sorts of different types of surfaces that can reflect a blast injury. So you have to be aware of the ventricles that contain fluid in the brain as well. Remember, the fluid's non-compressible. And here's an example that my son showed me of something on YouTube where it's a speaker vibrating some paint, just to give you an idea of what fluids can do when they start to move suddenly. So every one of those little droplets of paint or in our skull, the cerebrospinal fluid, can suddenly become a non-compressible projectile. And that's what really can disrupt the whole network of axon flow in the brain. So let me ask you a question. if you become an expert, how many of you currently treat concussion right now? Raise your hand. So almost all of you. If you haven't, you've learned a lot this weekend. There's a lot that I couldn't cover, but these are the types of practitioners that I work with, not specifically on blast injuries, but these are the referrals, the type of referrals I get when I'm just with my reputation of treating functional neurology cases in the last 12 years. And I have good relationships with all these people, and I send them cases, and I refer to them, and they send me people all the time. So let's talk a little bit about interdisciplinary care. If you haven't realized, when you're treating blast injuries, there's not a way you can bear this load alone. But we sometimes think we have to. We think we have to take it. If I just have enough sheer will, grit, determination, I can take that. But in reality, we realize that we have limited capacities and we have limited time, and there's certain things that aren't in our scope of practice that we need to rely on others. So share the load. And when you refer to others, there's some challenges, but there's also some definite benefits. One of the benefits I really like is the mastermind principle. When you're taking 2 brains or 3 sometimes, and you talk about a patient case, you actually create whole new opportunities that you never would have thought of just by sitting in your own office. So you also get a new perspective. Now, I really, all the cases that I treat interdisciplinary-wise tend to be more serious cases, but they tend to have much better outcomes. And that's helped me have more confidence and treat some of the less severe cases much more effectively. And as Dave mentioned earlier this morning, the key is doing more of what you're excited, doing more of what you love. So if you can have people on your team that can help you with that, it makes a big difference. So there are a few pitfalls. Make sure you pick up the phone, share your notes, find a way to streamline that communication because you don't always have time to do it. All right. Last couple of slides I want to share with you have to do with outcome assessments that I think are valuable. These are outcome assessments I use in my office. Acute concussion evaluation is really helpful to help me understand. The Rivermead's a good one to rate improvements. The sleepiness scale and the mini mental status exam I use when there's those symptoms. And then I like the graded symptoms checklist. I haven't used the SCAT tool as well, but since this has to do with brain injuries, I figured I'd include it. And I did include, and I will include in your Dropbox file a copy of all these questionnaires so you have them. And then especially the military history questionnaire, which I found was very helpful to look at previous military questionnaire type questions that will help you understand their history a little better. Things you might not have thought about, but it includes things about medications and surgeries, which most of the time we do ask about. So there's a few screenshots of this. Really like these outcome assessments. I really want to encourage you to use and gather some forms that really help that you understand how to interpret because there's not enough time to ask every one of these questions in person. So it helps you to use not only just to get more information on what direction you want to go for treatment, but also to cover the different areas that are most important to the patient. And many, many times, as a chiropractor, people won't think of mentioning certain items in their history that they think it isn't really pertinent to chiropractic. But if I put them on these questions, they'll be like, oh, I didn't know you could help with that. I didn't know you could help with that. I'm like, yeah, well, that is part of your neurology, so we definitely have to pay attention to it. So I have a book list at the end of the presentation that you can read on your own, suggested recommended readings. This one was particularly salient for me last year. The Ghost in My Brain by Elliot, Clark Elliot. He's an artificial intelligence researcher and college professor. And one thing he talks about is with traumatic brain injury, there's always an increased risk of suicide. And it's not a great, exciting thing to talk about, but sometimes those factors are real, and you have to be able to have people on your team that can help you deal with that. And you have to be able to ask the simple question, have you thought of hurting yourself or harming yourself? And you need to be able to have somewhere to take those people if they answer in the affirmative. The sad thing about this, and if you have treated concussives, brain injury patients, you know that this is true. It's very similar to depression patients who just don't feel like they're themselves anymore. And they feel like they already have died. They're just not themselves. And so they want to just return home. And it's not so much that they just, maybe they don't have hope, but maybe they feel like it's more walking to something, just moving to the next step than it is walking away from things. And you just have to provide support on that front. So in summary, why is this important to you? Well, you got to take care of your brain. You need to have more resilience. There's so much more that you can learn and study as you go deep into this, but it's important for your family. Almost all of you have had concussions, and almost all of you know people who have had concussions. And if I had another survey about who's been affected by chronic pain in their family and had those who've either overdosed or taken their own lives, then you'll know that this is a very profound effect. Last October, I had a phone call 2 weeks after I saw this patient. I had just adjusted him, and I asked him a simple question. I measured his rib expansion, and I asked him, so Lincoln, 101 minus 99, what is that? Tell me how much rib expansion you just had. And he's like, I'm not really good at math. I was like, okay, well, think through it. I'm adjusting him and talking to his mom sitting there, and I'm like, all right, 101 minus 99. He goes, no, I don't think well under pressure. And he's a really smart kid, really liked to think deeply about things, but I could tell that he'd been having a really tough time. So I put him on some therapy after we finished his adjustment, talked to his mom. I was like, Karen, what is going on with Lincoln? Has he been talking about hurting himself? Is there something that's going on? He says, yeah, we've had a tough summer. I'm like, well, we got to get some oxygen to his brain because he's not connecting the dots right now. And she said, yes, we'll get him in next week. And I said, we got to do some hyperbaric. We have to pull out everything we can to get this brain functioning. Now, he'd had long-term effects with chronic respiratory issues and chemical sensitivities. So he'd had chronic hypoxia since birth. And when I got the call 2 weeks later, that from his grandmother that he'd taken his own life, it wasn't a happy time. I went to the funeral later that week, and I waited to talk to Karen, and she just hugged me and nearly cracked a few ribs of my own. She said, I'm so sorry, I should have brought him in the next week, I just didn't have time. And I said, you don't blame yourself for this kind of a thing. This is something that you just need to realize we just do the best we can. And so my encouragement to all of you is whether you're treating someone, we talk about our military and we talk about, people we love, what's a hero to you? To me, a hero is someone that basically does something and risks what's important to them to help someone else, and they usually aren't asked to do it. And we look at our military service members and what they sacrifice and they risk. It doesn't matter whether you're treating slip and fall concussions, whether you're treating motor vehicle collisions, or whether you're treating blast injuries. When you go to treat these injuries, you need to bring your best game, and you need to have your best team to do it. And it's an honor for me to be able to help give people hope as they work through these healings, and not make them be defined by the damage and the trauma that's happened to them, but bring families, bring mothers, and bring fathers, and provide the families unit so that they can stay together and optimize their brain function the best they can. So that's all I have for you. Thank you.